All right, so call the December 3rd REMAC meeting to order with a salute to the flag and then a brief moment of silence. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Please remain standing for a moment of silence as we keep it, those of our loved ones, those first responders and soldiers, officers in our hearts, especially those who have suffered or had suffered the final ultimate sacrifice. Sorry, I was trying to figure out what I was going to say. Thank you. Please be seated. We do have a quorum. We have 9 doctors. We need 5. We received excuses from Dr. Winslow, Dr. Harris, Dr. Passive, Dr. Rowe, Dr. Gujral, Dr. Vermonti, Dr. Keenan, and Deputy Supervisor Jim Amelia.
I just received one from Don Barrios.
Dr. Barrios too. Okay. Doesn't count. I didn't get it.
Yeah.
All right, so put her down. The last 2 sets of meeting minutes were emailed out. I need a motion to approve both the August and then October. Sorry. Okay. Any body against? Okay, so moved. All right. Our attendance needs to be reviewed. It wasn't sent. Was attendance sent out? No, it wasn't. We're going to send out attendance so that you guys could keep track. Please be sure that you come to the meetings. We do have a meeting attendance policy that if you're not excused and you have 2 unexcused absences in a row, according to the REMSCO bylaws, that's considered you've left the committee. But we're pretty generous, and we typically will ask for your intent. I don't know what the stats are for the attendance, so I won't review it. Incoming correspondence. There's one brief correction to the agenda. I had under the whole blood tag, Dr. Ryan, it's Dr. Polides, so my apologies. The New York State Compliance Bureau minutes being read into them, Compliance Bureau notifications have to be read into the minutes. First one is EMT Anthony DeLuca, 453174 for violation of Part 800.3 AM, 800.3 AL, and 800.15 A2. Certification is revoked effective 11/19/25. Assessed a civil penalty of $8,000. Henry Loriano, EMT 538468 for violation of 800.15 A3, 800.16 A1. Certification surrendered effective October 24th. And then Rafael Quinones Rodriguez, EMT 511258 for violation of Part 800.15 A3, 800.16 A2, and 800.16 A3. Certification surrendered effective 10/8/25. So a lot of people got affected this last 2 months. I received the data from medical control regarding radio and phone notifications and diversions. So thank you. There was a letter received from a community member who's also a REMSCO member. I have it here at the table if anybody wants to read it. It was sent up to the state, so we're waiting to hear what the state has to say about it. That'll be the last moment we'll discuss that letter. I received an email from Dr. Zito asking about the order of open seats for membership. And just for everybody's information, the order of the queue for open spots, should a seat open up, it goes to Dr. Sanjay Shetty, then Dr. Joseph Zito, then Dr. Erica Schwartz-Cohen. Let's see, moving on. Lastly, in the Inwood Fire District, this is hot news, has notified the REMAC and REMSCO that they lost their controlled substances and were downgraded to BLS until further notice.
Sorry, lost their controlled substance license, not their controlled substance.
Thank you for clarity. Yes, that would be, there's a big difference there. Yes,
Sorry to interject.
no, please, thank you. Um, Thank you very much. And then, the outgoing was just the bi-monthly request for, some medical control for the information. With regards to reports, I'm just gonna jump right ahead. And Bro, if you have a vice chairman's report afterwards, please go ahead. I'm just gonna read this, so this way I don't skip it. I hope everybody had a wonderful Thanksgiving. There's certainly a lot to be thankful for. I'm thankful to all of you for your years of service and guidance in helping move our region forward, for improving goals of care, quality, and communication. We have made great strides in medical director engagement, interoperability, and MCI care, protocols with airway and RSI quality, and a reinvigorated quality committee we're now looking forward to maintain these projects and continue to build a robust dispatch process, including EMD for all EMS service calls, with the goal of getting the right ambulance to the request for service at the right time, minimizing delays all the way. I will continue to serve and assist, providing guidance as I step away as the regional medical director and REMAC chair at the end of this term. I'm hoping that you will find that Dr. Newbert to be as fierce an advocate of EMS as I am. Also, he has new perspectives and ideas. Please support him as we go into this next year. And all the members, I will continue to support and represent our region at the state level, supporting good medicine. Wishing you all a blessed and happy and safe holiday season, with time for your families and yourselves and your friends. All the best for the new year. It has been a true privilege having the opportunity to lead this group of dedicated folks over the past 9+ years as chairman. So thank you for letting me read that.
Yeah.
Finally take a breath. All right. So see,
We know where you live.
yes.
See the extra gray hair there?
Yeah. My hair's gonna start growing back. So CMAC, there's no report. Actually, Vice Chairman, you have a report.
Hard to follow your lead, but I'm doing my best. So I want to also say thank you to the committee. I want to say thanks to all of you for your hard work, your dedication, everything you do in the hospital, in the community. I've had a run of over 20 years, a lot in the front here. I can't wait to take a back seat. I'm going to be sitting all the way in the back. And I would just say that I have a lot of hope. So I'm very encouraged. Dr. Newbert is a incredibly energetic, thoughtful leader. I know he'll incorporate all of your thoughts and do it in a mindful way. So I have a lot of hope for this county and for everything that we do for the people we serve. So again, thank you for everything and allowing me to lead for so many years and be a part of it. Appreciate it.
Nice. With that, CMAC is gonna be December 10th, so there's no report. QAQI, Dr. Silver.
All right, well, mine's gonna be a lot less interesting than both of those. So we met last week for the REMAC meeting, and there were 3 different reviews that were done. The new QA stance and committee's position, as we discussed previously, is that our job is to help support agency medical directors. And in our reviews, we're only really getting involved in looking at systemic issues that affect countywide care. This is not an individual provider or agency or anything like that type of approach. So what we're going to do is that at these meetings, we're going to bring forward if there were any systemic things for the REMAC to hear. We're then going to put that information out for all of the agency medical directors for them to bring to their providers, and to, as a extra layer to make sure people are hearing it, after the REMAC meeting in that weekend or that week's EMS coordinator report, there'll be a section on there as well, reinforcing the things that came up that we reviewed. So the 3 that we came up with this time and recommendations from the QAQI committee is recommending that anytime you have a critical peds patient, we don't see them often enough, and to have some sort of peds reference device. Most of us use the Broslo, know where it is in your ambulance and rely on that, because if you get into a situation, it's gonna make remembering your doses much easier than trying to pull them from memory. Second recommendation that came up was, once your advanced airways are placed, using a C-collar to help stabilize and secure your airway, which is actually in the collaborative protocols as a strong recommendation. And the last thing that came up was with regards to AMA of minors when parents are not there. The recommendation after discussion was that the medical control calls are recorded. So putting that through to the medical control doc with the parent. If the parent is insistent on AMA and does not want to come to the scene, that AMA can be secured, and the police officer who is there can serve as the witness to that, not as the person taking the AMA, but the witness to the AMA being signed. At that point, EMS involvement has completed. You guys go back in service, and then the police department or whoever else is there can work on getting that minor back to their parents or wherever they need to go from there. With regards to some of our other projects, we started a stroke project a couple months back. For those providers in the room, you guys have been doing well with the new stroke notifications. We've reached out to the hospitals to get an idea of how it's actually affecting patient care. We've only heard from a couple hospitals so far. We're only a couple months in, but of those hospitals that we've heard from, they have seen an improvement in their door to CT time. And they're also noticing that they are getting more pre-notifications and being ready for agency arrivals. What the committee would like to ask all of the agency medical directors and providers as well to do is, if you are getting the hospitals after making a stroke notification and they are not waiting for you or put you in a corner instead of taking your notifications, let the committee or someone on the committee know, because obviously this is a two-way street. It's not just about EMS doing notifications, it's about them responding to EMS appropriately. And then the last thing, while we're waiting for more stroke data to come in, is we're gonna look to start a review of cardiac arrest in the county, looking at the ROS percentage, who's being transported to hospitals, and who should be, who should not, based on the collaborative protocol recommendations. With that, I will stop speaking. See if anyone has any questions.
No.
I yield back the floor.
Just really quick, the airway committee, when we do our reviews, we'll also piggyback with that and put our recommendations out with the QA committee. So if there's anything that comes up systemically, like recommendations for airway, we'll also bring that and put that in that same report. So it'll be connected.
Good. So, Airway RSI.
We had good discussion. Few things on the agenda to be voted on. The first is that the state has come out with their new policy for supraglottic airways for BLS. So it was in the collaborative protocol, but there was not a policy that supported that. So that policy is out. It's 25-09. So the committee put a motion forward that we're going to continue to follow the standards that we've been following as part of the pilot program, that we will recommend that all medical directors follow the state policy, and that the training will be there's two state classes on their platform on collaboration. It's going to be the supraglottic airway training and the BLS capnography training. So that's what we want the standard to be. So that comes as a seconded motion from the airway committee, that we follow that policy, we follow state training, and that medical directors will confirm the standards and report to us also. So everyone knows there's now an application in that policy. So if another agency wants to come on board, they need to fill out that form, that state form that's in the policy, and then they'll notify the REMAC, and then we'll approve it at the REMAC level. Correct, Don? That's how they're doing that?
Yeah, there's a portal, like those of you that have been doing vehicle renewals or anything else like that. It's a state online portal. You fill that out, you attach the required documents, that then bounces back to the region. Take it.
And then we'll take it. Also, any agency that was participating in the pilot does not need to reapply. They are automatically approved to continue practicing at the level that they were practicing during the pilot. that this is only for new agencies that want to come on board with supraglottic airways for BLS. The second part, we tabled the request from Hicksville to be an RSI agency because we did not have the medical director with us, so we'll table that till next meeting. Belmore Merrick EMS put a application forward and that was approved, so that'll come as a seconded motion to approve Belmore Merrick EMS medical director is Dr. Silver as an RSI agency. We had a good discussion about surgical airways and following the protocol. And then under providers, we clarified a few questions about last time. We just had a few documents we had to clarify for providers that got approved last time. That was all good. And then we have one person to put forward, Robert Kane, as an RSI medic for Belmore Merrick EMS, passed unanimously from us. So that comes as a seconded motion under new business. And then Dave, if you could read and then we had a discussion about our current policies to match the way we've been practicing. And so we brought forward a motion to amend our policy manual, and Dave has that because he wrote that down.
All right, so the motion, which we're bringing up under new business, is to change regional policy manual to state under line 1, must have active practice, New York State DOH certified paramedic card, be in practice for 3 years, and then subsequently remove line 2 and renumber lines 3 through 11.
So that'll come as a seconded motion. That's just to clean up the way that we're practicing, because that matches the way we've been coordinating with our medical directors. And then the airway data form, everyone will be happy to know, has been made simpler. So we do bring a seconded motion just to approve those changes. So the committee vetted it. We took out the fields that we thought were duplicative or not necessary, because we could get that information from the charts, and then we just basically simplified it to make it easier on all the providers. So we just like to go ahead and that comes as a seconded motion to approve that simplified form. We listened to everybody. That was from feedback from all of you that form was too complicated and too much. There was too much being asked, and we have made it, and we also reorganized it to make it more user-friendly. The idea is that we just want to make sure that we're watching our airway data, but if we need to get full information, we could always go to the image trend bridge and do a study there. So therefore, the simpler form should be easier on everybody. And then, two things from that discussion, and then I'll be wrapping up. One is that for all the medical directors and for all the providers, it's really, really important that procedures go in the flow chart of your EPCR. If we're going to be pulling the data, we need to be able to pull it from the flow chart. So you can't write it just in the narrative. So intubation attempts, medications given, anything, any advanced airways, all of that has to go into the flow chart. That's super important for us to be able to get that information if we need it. And then we talked about what is an attempt. Any placement of an invasive airway or of a blade inside the mouth is considered an attempt. So just to be clear, if you're in and out of there 3 times, you can't say that is one attempt. It has to be, each time that you're doing a procedure, it is considered a separate attempt. And then just for educational purposes, we talked about making sure that any kind you're doing, for RSIs, but any airway, making sure you do good pre-oxygenation. That you make sure that you maximize your hemodynamic stability if you have to prior to intubation, and then make sure post-intubation that you manage sedation properly and monitor the vitals post-intubation. And those comments will go with the QA comments as best practices. Yield back to you, Chairman.
Any questions?
So I just had a question. I apologize for not being at the airway. So if you're looking in the mouth, oral pharynx, or secretions, maybe to clear it with suction, that is considered an attempt.
Yes.
No, just for suction, as you're saying.
Well, I mean, if you're looking, you take a blade, push down the tongue, and
That's an attempt.
But not for the purpose of intubating. I don't think.
so I just want.
Yeah.
That's not an attempt.
For the spirit of it, if you're attempting a advanced airway, if you're putting an advanced device in there, that's an attempt.
If your intent is to put the airway in.
Yes.
Got it, okay. Thank you.
We'll parse that and that.
Yeah.
I had heard any time that.
All right, Dr. Ryan.
Yes, okay. So we had a meeting back in September 18th. Unfortunately, I couldn't be at the last meeting. David, I'm not sure, did you discuss this in detail at the last meeting, or should I bring it,
Go ahead.
discuss it?
No, go ahead, Jim, we did.
Okay, okay, all right, so we have three things on the agenda. The first one was TXA. This has been some recent literature out. There was a well-designed study, which looked at TXA in short transports. Did not really show a significant benefit. Despite that, there's been a lot of literature out there that has shown a benefit. We did not see any downside. There was not any risk shown in that study. So our overall feeling of the committee was not to change our current TXA protocols. RTAC has thought it was good that we use it. So I think it's in the protocols now, no need for any change, but we're continually watching the literature on that topic. Second topic we had was push dose epi. It's probably gonna sound like a similar discussion, but push dose epi is used in hospital and pre-hospitally. It does have the benefit of briefly elevating blood pressure. The potential downsides are arrhythmias and hypertension or mixing the wrong dose. Not been a lot of data to suggest that occurs often or there's a lot of side effects. There is no evidence really that it affects long-term or intermediate-term morbidity or mortality. So you're briefly raising the blood pressure, but the patient may not do that. We don't know. Most people look at it as a bridge to, if you need that in the short term, you're probably gonna need a drip afterwards because it's only gonna last 5 to 10 minutes. With that in mind, in the absence of any adverse events in the literature and is currently in a protocol, we felt there was no need for any change in the protocol. And once again, we'll keep our eyes on the literature and see if anything shows a long-term benefit or adverse reactions to that medication. And the last thing we had was pre-hospital blood transfusion, and that has really been transitioned over to Dr. Stan. So I'll leave him to discuss that. And Chairman, is it too appropriate time, or should we discuss that later?
If you want to wait till Dr.
Whenever-
Reedy goes, then
whenever
we'll
it's
discuss it. Yeah,
Yeah.
why don't we
No, I
discuss
mean,
that?
he's able to, okay. Right, and that's all we had from the protocol committee.
Okay, great, thank you, that was great. Oh, also, New York State collaborative protocols are going up to CMAC for final approval. So the draft should be on the New York State website. And we're voting on them next week, so that once approved, they'll be implemented in July 1st of next year.
Yeah, I think the big change that at least I saw was about the OBGYN hemorrhage and
Maternal
pre-private. That's gonna be a whole separate protocol, which we'll see when it comes out, but I think that's the biggest thing I saw.
Yeah, there was a parsing out of that, and also neonatal versus pediatric care.
Yeah, and to your pressers, the norepi and epi drips are becoming standing order for certain situations.
So under credentials, there was no committee business to be had, so there's no report. Policy Subcommittee, Dr. Vermonte asked for an excuse. Anybody have anything for the Policy Subcommittee? That we're going to discussing them. Okay, RTAC, any report?
No,
And then eBridge,
Yeah, so the ComTag, just reporting on some data as we have been doing every other month here. Last time we spoke, we had over 44,000 eBridge communications. As of end of review November, we had 53,440, or a change of about 9,000 increase. So that's a great number, and congratulations to everyone. As far as major notifications, there were video calls. We've been tracking those. We're in the 170 range, and we've eclipsed. We're up to 218 video calls. Very effective use of the eBridge technology. Trauma perspective, we were at 655. Now we're 793 for the year. STEMI, 144. STEMI through eBridge now at 171. And then finally stroke, we were at 820 using the eBridge, now at 985 as of last look, again in November. Of note, those eBridge activations which were not acknowledged, something that we're studying. How many times are you sending information in the hospital not either receiving through the not acknowledged? we were at 150, we've only gone to 160, so it seems like they're acknowledging a lot more, considering all the volume I just shared with you. So again, really great work, using eBridge as a tool for communication. And I would just add on to maybe my comments earlier. It's really refreshing to know that 20 years ago, when we were having conversations, we were very empiric based, very, emotion based, but now we're becoming very data driven, and it's really nice to see as an organization to be able to use numbers to help drive success and change. So that's all I have. Any questions?
Okay, moving on. EMS modernization tag,
Still on holding.
okay. And then the medical control tag, the same thing. I've been busy with some work stuff, so neither myself or Jim have had an opportunity to meet. Or I guess have hold a committee meeting. Hopefully to re-engage the committee in February. Whole blood tag.
Thanks. So, we started a tag to look at the use of pre-hospital whole blood. We've had two preliminary meetings, myself, Dr. Ryan, Dr. Newbert, and Cole, who's been very, helpful in getting some data for us. It's an emotional topic. There's strong feelings and opinions on both sides of giving whole blood out in the field. But the literature clearly has a lot of benefits. It shows a lot of benefits when it's used, the particular within the protocol under stringent guidelines, even in areas with very quick and close tertiary hospitals availability. So we've seen a decrease in morbidity and mortality in a lot of these cases, and it's being used by some major fire EMS organizations around the country. About 250 departments are currently using whole blood. In New York State, it was approved back in 2024 for pre-hospital care. It is in the collaborative protocols along with the TSA and the use of whole blood out there. So yes, this is, there's strong opinions on both sides. That's why we formed a tag. We're going to be looking at it. First, we're going to use some of the eBridge data that you just talked about to get some hard facts as to, is there a need based on trauma calls in the Nassau County area to even look at a problem such as this, or a solution such as this. Two, we're going to try to ask if we could include in the yearly survey what departments might be interested in even doing this and holding cold blood, because there will be a cost to it. There'll be certain types of refrigerators that are needed, freezers that will be put into the units to store the blood, which we sort of saw back in the day when we were using chilled saline in our ROSC patients, when we all had to run out and buy refrigerators for our ambulances back then. But there is a cost for that. A lot of those units are fully computerized. They're able to digitize the temperature and create records, which is going to be needed to get the blood from a blood bank. Blood banks are a second place where we're going to get the blood from, and how we're going to store it, and how we're going to basically return it if not used before expiration date. So these are all the questions that we're looking at trying to get answers for in the tag. And the third reason would be, the feasibility of it actually going out to Nassau County. So we started this tag. We're offering up anybody who wanted to join it. I know several of you approached me on the side and would like to join. We'd like to have you there from different sectors, fire, EMS, etc., to work together with us, and we'll put together a report that we can present to the protocol committee and to you people here at the meeting to see what your thoughts are going forward. So that's my report, Mr. Chairman.
Great, thank you. And Jim, did you have anything else you want to say?
No, but yeah.
Any questions? Thank you for getting that going. It's a great discussion to be had. All right, Remsco Chair David Caldor for another.
I have no report, but I would like to thank the REMAC for all your help over the last year.
Very well.
Thank you, Dave, for service.
Thank you. All right, anybody from the Nassau ED committee? Okay. All right, Don Hudson.
State meetings are Monday, Tuesday, Wednesday of next week. We'll be making a trip up to Troy, so report back, as you said, the collaborative protocols are on the agenda, along with a bunch of other stuff.
Okay. Easy, any questions?
Yeah, happy holidays.
Yeah, and please be sure to share Don's report if you get it with your agency members. Full of good stuff. So anybody from the fire marshal's office? Okay. Old business, the PSAP tag, Dr. Harris is excused. Any other old business? Okay. Your new business, we're gonna start with, elections. Just to get it out of the way, since there's a slate that was approved at the last meeting with, that was uncontested. I'll read the slate out loud. The slate, that was approved at the last meeting and also approved by the REMSCO at the next meeting is, the 2026 to 2028 term. The chair, Dr. David Newbert, vice chair, Dr. David Kugler, secretary, Dr. David Silver. And if you want to run for office, we're making a sub policy, you have to be David, no. I just need somebody to make a motion saying cast one ballot. Okay, great. All right, so Mr. Secretary, sign away. That's our ballot.
All right, will do.
Great. All right, so those are our officers for next year. Good luck, congratulations, and Zag is in. Okay.
Thank you, everybody, for the vote.
Yeah.
I appreciate you.
Sucker.
I'll let you know in 2 years how I appreciate that.
All right, and for airway, we had a bunch of different motions. The first one was to, the airway committee is bringing forth a new RSI agency, Belmore Merrick. The committee approved that agency to be authorized as a RSI agency. It comes as a seconded motion. So I guess we'll just have a vote. All in favor? Anybody opposed? Anybody abstaining? Okay, so that passes. Congratulations to Belmore Merrick and Dr. Silver. There was some old business from the airway, just as an update. We were waiting for some documentation to be submitted on paramedics Tilly, Paco, and Castro. Those documents were submitted, received, and approved. So those medics are formally RSI medics with the approved documentation. Let's see, there's one issue that was tabled, and then there's a motion for a new RSI paramedic Robert Kane. He was approved by the agency, came with great letters. And so as a second motion, I need, we'll just hold a vote. All in favor of making paramedic Robert Kane a RSI medic? Anybody opposed? Okay, that passed unanimously. Okay. From the RSI committee came a motion to change our regional policy manual. This has to go from here to the REMSCO to be approved. And if they approve it, then we can change the policy manual, but it makes great sense. Just to facilitate RSI in our region and prevent a bigger agency from sort of inserting their leadership opinions. Section of the policy manual under line 1 to change it to the must have an active practice New York State Department of Health certified paramedic card, be in practice for 3 years, period. The next part of the policy change would be to remove line 2 and then renumber lines 3 through 11. So that comes as a seconded motion. Yeah,
Sorry, I believe the word was recommend 3 years. I don't think
Recommend
it
3
said
years.
3 years.
It's in there.
Yeah,
okay, be in practice for 3 years, not so.
Oh, recommend 3 years.
Recommend 3 years.
Yeah, okay.
Keeping up that same.
Okay, recommend.
Yeah, recommended.
To be in practice.
The
Okay,
having
got
the New York State active
Thank you.
card is mandatory.
Okay, and then, all right, so thank you for the correction. So with that, all in favor? Anybody opposed? Okay, great. So that passes. We'll send that up to the REMSCO for their review and approval, hopefully. There was also a motion at the Airway Committee to modify the U-Bridge form. to make it more streamlined and user-friendly. There were other recommendations made that we would move the most used procedures at the top, make the corrections so that the medications were not abbreviated, but rather spelled out. And so we were trying to make this a form that we could actually use to collect data, not a form that's gonna be another PCR, because the PCR is the PCR. And we want our providers to use this and not have to make a phone call afterwards. So this is the easiest way to do it, is just keep it simple. Put the common things on top and then move down as we go in using it. The motion comes as a seconded motion. If there's before I call for a vote on the motion, I would like to ask if there's any questions about the changes to the form. Okay, so
I
because,
have a question, just technical question. Are they absolute? Meaning could the eBridge say, look, we can't do this and push it back, or are they gonna comply with whatever we tell them to do?
they'll comply with whatever we tell them.
Oh, yeah, Don already
They're
did
ready
it.
to mocked up.
Yeah,
Yeah.
yeah, they're ready to go.
Yeah,
We just wanted to make sure we brought.
we need to get everybody's approval before we hit the button.
Great.
I know what you're saying, and we're getting close.
Right.
Yeah.
but we're not there
Yeah,
yet.
yeah, no, they had already approved it. We just wanted the body's input first.
You read my language.
I'm right with you.
All right. And so, all in favor, the changes? Anybody opposed? Okay, that's passed too. That's great. All right, and Dr. Newber, you had said that you had something about a pilot project.
So, yeah, if Cole can come up and speak to everybody, basically in Suffolk County, I also sit as a non-voting member in the Suffolk County REMAC. We have a pilot program that we are working on with them for Keppra, for repeated seizures. Suffolk County approved it as a pilot, and we would like Nassau County to be part of the pilot. So I'm gonna have Cole present and then we can talk about it.
Good afternoon, everyone. Like Dr. Newbert said, we're in both counties, to cross the border. So the rationale for this project basically comes to the fact that Suffolk County doesn't have MFI. It's an RSI only county. So if you do have a patient who receives 2 doses of benzodiazepines, medical control is contacted and ketamine is given, the patient stops breathing and an endotracheal tube is placed, it's considered MFI. So looking at alternative ways of managing seizures, Keppra was thought of as a possible option as a pilot program. With that being said, there is a couple places that are already doing it. New Jersey adopted Keppra this past August. Rhode Island's already doing it. And Kentucky, Maine, South Carolina also have it in their formularies as new medication without a protocol yet. Looking at the safety profile of it, it's a very safe medication compared to the alternatives, valproic acid, phosphatoin. And it has only a few minor side effects when being aggression, but it's in less than 2% of patients. And it is safe in children and pregnancy. Looking at the numbers, I'm a volunteer with Comac Ambulance, and we were looking at Suffolk County data. I don't have any data from Nassau County, however, but in Suffolk County, we would have had 16 uses since May of this year for Keppra. Considering trials in evidence-based medicine, the Rampart trial in 2012 showed that IM benzodiazepines were the best route for a first-line medication. So this would not be replacing benzodiazepines in the field. It is not a medication for terminating seizures. It uses an anti-epileptic drug in preventing recurrent seizures. Looking at the big ESET trial, Keppra is equivalent to valproic acid and phosphatoin. So this is why we were opting for this medication versus the other two. There's no difference in efficacy, and it does have that better profile overall. And looking at Europe, SAMU, which is France's ambulance service, trialed out Keppra in the field. That study did have an issue where they were doing too low of a dose and waiting too long to give in the field. They found in their study that at a higher dose, it might have had a better outcome for the patients. And the American College of Emergency Physicians and American Academy of Neurologists recommend Keppra, ASAP for in the hospital in the ER, and AAN actually included paramedics in their formulary for a second-line agent being Keppra. The cost for Keppra is relatively inexpensive. It's $5 per vial if it was to be purchased, with the average patient needing about $20 to $25 worth of the medication. Epinephrine in a vial is $25. Glucagon is well over $200 per vial. So it's a very affordable medication to trial out in a pilot program. And the protocol that we are looking at is first treat our patient with midazolam, 10 milligrams IM or IN, or 5 milligrams IVIO of midazolam, followed by that second dose. And then for patients who have a known seizure history, not their first time seizure, or have had multiple seizures, we'd consider Keppra 60 milligrams per kilogram IV or IO as a push over 3 to 5 minutes with a max dose of 4,500 milligrams. In doing research and investigating on the back end, the Northwell Health System and Mount Sinai Health System were reached out, and they do have neurologists that are in support of this. We're waiting to hear back from Catholic Health Service, as well as some other hospitals in Suffolk County. So what I'm looking for today is a motion from the REMAC to put forward to bring this along with Suffolk County to the Medical Standards Committee, hopefully have another treatment option for our patients who suffer from seizures. But you have any questions?
Can I just bring up a couple of points? So
Yeah.
just in terms of, you brought up a good point that Keppra is an anti-epileptic medication. It does not treat right away a seizure that's actively there. So when you brought up the fact that you've had now a seizure, you've given Valium, you've given a second dose, and now you're moving on. You're saying that it's going to replace, when a patient is having another seizure, you're saying you're going to give this medication instead of a medication like ketamine or something else?
So
In terms of managing the seizure?
Yes, doc. So we're using two components. We're using it to prevent recurrent seizures in our patients. And we're trying to hopefully avoid, or at least it's up kind of the idea was we're trying to not go to that ketamine route. We could avoid it. And now this is another
You
agent.
still would if you had to.
If we had to,
It
we
wouldn't
would.
preclude you from using it, but the idea.
It's
Yeah.
great if you're going to try to prevent a seizure. If you're in
Correct.
the
That's
middle
the
of a
goal.
seizure, given Keppra.
Yeah,
you're
no,
not
yeah,
gonna
it's
get-
meant to prevent future ones, not to, not.
Yeah, we're
to-
not using it as a
prevent.
termination medication.
Yeah, and it's clearly stated in the policy or the pilot when we did that, yeah.
Okay.
Time, I'd like to make a motion.
Yep, and I'll. Yeah, yeah.
Wait, a question.
Any more questions?
Is it Versed, wait, Keppra, or is it Versed with Keppra?
Versed Keppra, if they have epilepsy or they have had multiple
Right.
seizures.
So
It's
if their second
Versed
seizure.
plus Keppra?
Would
That would be the best way.
Yeah, so is that,
That's where, you know.
that's what I'm saying, is it Versed with Keppra or Versed, then Keppra? You're still waiting that extra couple 5 minutes for the continued seizures.
So a lot of this is also brought to med standards. The neurologists we've reached out to, are very open to it. For us in the field, it's a little trickier than being in a hospital setting.
Yeah. Yeah, guys, we have the protocol, we could share it with everyone, and we're still tweaking it because we're coordinating with the neurologists. Basically in Suffolk County, they reached out to all the different systems and they're working on making sure the protocol matches what the neurologists recommend.
Do you want to send it to the committee to look at, and then we could bring it up at the next week for approval? Because, I mean, we're voting on something that.
The pilot hasn't got forward yet, but it has to,
I think we're voting on a concept.
Correct.
And not on the
yeah,
specific.
we'll bring back, so everyone's clear, we're still working on the actual wording of it, and it won't go to medical standards until February.
Just to be a joint region on this pilot project.
Correct.
That's what we're.
Correct, and then we'll bring back the final protocol so everyone's aware of it at the next meeting, so that way everyone
Yeah,
can see it.
just in terms of, I just wanted to mention Dr. Silver here. If you are going to give this to break a seizure that is going to occur, I would agree that if you have to give a second dose of Versed, that's when you want to give your Keppra. Because you want to prevent that. You don't want it to be the third line of medication when you're already dealing with status, right? That's not going to help. That's going to help us in the hospital later on. It's not going to help you or the guys in the field. You want to give it with the second dose. So just take a look at that. with your
So if it's okay, the motion will be that we join the pilot and that we'll come back to the next meeting with the protocol. and
This is
we'll update everyone.
this is an introduction. Now we're going to clarify it, hopefully go to protocol committee.
Yes,
before-
correct, but we're in agreement that we'd like to do this pilot with them and then we'll come back with
Dr.
the,
Silva, Dr. Matthews' points are well taken, and they should be incorporated in that final decision.
yeah, and if you guys reach out, we'll put you in touch with Dr. Winslow. Dr. Winslow is doing this with Cole in Suffolk County, and Dr. Winslow also sits on our body, so we'll be able to coordinate.
There's a question.
Oh, I'm sorry, question in the back, JJ.
Okay, just from a logistics perspective. Shelf life, and are there any particular storage you should see to worry about in regards to refrigeration?
No, nothing with refrigeration. They should follow that same timeline as other medications, just depending where it's acquired from.
Okay.
Obviously, if you get it from a hospital pharmacy and they're giving you something a month, then you're getting a month out of it. But if it's being purchased
It's not one
logistically,
of those, it's not one of those mandatory ones you have to be stocked every 30 days.
No.
No, okay,
No, and it's not controlled, which is the other nice thing. It's not a controlled medication.
thank you.
All right, any further questions on the motion to join the pilot from Suffolk County? Okay, like to have a vote. All in favor? Anybody opposed?
Thank you, everybody.
Yeah.
And we'll get you guys in touch with Dr. Winslow. Just to email me out. I'll get a chain together with us, okay? Thank you, guys. Thanks, Cole.
So that was it. Anything else under new business? Just before we make a motion to adjourn, I just want to thank everybody again for this past year, for your volunteering on our committee. It's 6 times a year that we meet. And each time we meet, we have great discussions and we keep making baby steps towards improving the care provided in the Nassau region. We've made so many great strides. There's still a lot to do. So please keep coming. Please keep volunteering here. I wish you and your families nothing but the best for the holidays and for the next year. May you all be healthy and well. I need a motion. Motion to adjourn, Dr. Shearson, Dr. Kirshen. Okay, it is now 3:06 PM. Thank you, everybody. Be safe.